Question 1. Mr. Thompson, a clinical laboratory technician, has just received a urine sample for analysis. Upon examination, he notices that the sample has been improperly stored, causing significant changes in the chemical composition, particularly in the glucose and protein levels. According to laboratory best practices, what should Mr. Thompson do next? A. Proceed with the analysis of the sample and document the abnormal results. B. Discard the sample and request a new one from the patient. C. Modify the results to reflect what would be expected if the sample had been properly stored. D. Perform the test anyway and immediately inform the physician without further action. Answer: B. Discard the sample and request a new one from the patient. Explanation: the proper handling and preservation of urine samples are crucial to obtaining accurate diagnostic results. According to laboratory best practices, improper storage can cause chemical degradation, particularly in glucose and protein levels. When a sample is improperly stored, the results may not accurately reflect the patient's condition. The American Society for Pathology emphasizes that laboratory technicians must ensure that all samples are stored under the appropriate conditions and that only viable samples are used for analysis. Discarding the compromised sample and requesting a new one is the correct approach to ensure the accuracy and reliability of the test results. Question 2. Which of the following laboratory procedures is most likely to be affected by the pH of the sample? A. Enzyme activity in a blood chemistry test. B. The morphology of red blood cells in a hematology test. C. The results of an antimicrobial susceptibility test in microbiology. D. The quality of a blood culture sample. Answer: A. Enzyme activity in a blood chemistry test. Explanation: enzyme activity is highly sensitive to changes in pH, which directly influences enzyme function and reaction rates. In clinical chemistry, the pH of the blood or other bodily fluids is critical in ensuring accurate enzyme assay results. Enzymes have optimal pH ranges where they are most effective, and deviations from this range can result in either decreased or altered enzymatic activity. This MIC pH is a key factor in the interpretation of results from blood chemistry tests. In contrast, while other areas of laboratory medicine, such as microbiology or hematology, may see pH influence test outcomes indirectly, enzyme assays in clinical chemistry are the most impacted by pH levels. Question 3. Mr. Carter is a laboratory manager responsible for overseeing a hematology department. He has noticed that one of the automated hematology analyzers has been giving inconsistent results. The analyzer has recently been calibrated, but the quality control QC results for the past week have shown abnormal trends in red blood cell counts. What should Mr. Carter's next step be? A. Perform the test again using a different hematology analyzer. B. Send the test results as they are and inform the clinician of potential discrepancies. C. Investigate the analyzer's maintenance and calibration records and run the QC tests. D. Report the QC results to the regulatory body for further inspection. Answer: C. Investigate the analyzer's maintenance and calibration records and run the QC tests. Explanation: inconsistent results from a hematology analyzer, despite recent calibration, signal a need for a thorough investigation. The laboratory's quality assurance and quality control procedures are designed to monitor and ensure the reliability of test results. Mr. Carter should start by reviewing the analyzer's maintenance and calibration records to ensure the device is functioning correctly. Running the QC tests is essential to identifying if the problem lies in the analyzer or the test procedure itself. Option is not ideal since it may not address the underlying cause of the issue. Option B fails to address the potential problem with the instrument's functionality, which could lead to inaccurate patient results. Option D is premature, as the internal quality control process should be the first line of investigation before involving external parties. Question 4. A 45-year-old patient presents with a suspected autoimmune disorder. The laboratory technician performs an enzyme-linked immunosorbent assay, ELISA, for the detection of antinuclear antibodies on her. The result comes back positive. What is the next best step in confirming the diagnosis? A. Perform a Western blot test to confirm the presence of autoantibodies. B. Immediately initiate treatment for the suspected autoimmune disorder. C. Confirm the result with a second on a test using a different method, such as indirect immunofluorescence. D. Inform the physician to start a diagnostic workup for rheumatoid arthritis. Answer: C. Confirm the result with a second on a test using a different method, such as indirect immunofluorescence. Explanation: A positive result for antinuclear antibodies on it suggests the possibility of an autoimmune disorder, but it is not definitive on its own. On a tests are sensitive but not specific, and a positive result may occur in various conditions, including autoimmune diseases and infections. To confirm the diagnosis, it is best practice to perform a second confirmatory test, such as indirect immunofluorescence, which offers a more specific and reliable result for UNA. Western blot option A can be used to confirm the presence of specific antibodies, but it is not typically the step after a positive UNA. Starting treatment option B without confirmation could lead to unnecessary or inappropriate therapies. Option D prematurely narrows the focus to rheumatoid arthritis when the broader range of autoimmune conditions should still be considered. Question 5. In a microbiology laboratory, a culture sample shows growth of gram-positive coccate in clusters, catalase-positive and coagulase-positive bacteria. Which of the following organisms is most likely present in this culture? A. Staphylococcus aureus. B. Streptococcus pyogenes. C. Escherichia coli. D. Staphylococcus epidermidis. Correct answer, A. Staphylococcus aureus. Explanation. The characteristics describe gram-positive coccate in clusters, catalase-positive and coagulase-positive. Point to Staphylococcus aureus as the most likely organism. Staphylococcus aureus is known for its distinctive cluster formation, catalase positivity, which distinguishes it from streptococci, and coagulase positivity, which helps in the differentiation of S. aureus from other staphylococci such as Staphylococcus epidermidis. Streptococcus pyogenes option B is gram-positive but forms chains, not clusters, and is catalase negative. Escherichia coli option C is gram-negative, RON, and does not fit the description. Staphylococcus epidermidis option D is coagulase negative, which differentiates it from S. aureus. Question 6. A patient is undergoing a blood transfusion. During the transfusion, the patient develops fever, chills, and back pain. The laboratory is notified of a suspected transfusion reaction. What is the first action the laboratory should take to investigate the potential cause? A. Check the patient's blood type and the blood unit's compatibility. B. Immediately report the reaction to the hospital's legal team for further investigation. C. Perform hemolysis test on the patient's blood sample. D. Prepare an alternative transfusion unit for the patient to continue treatment. Answer. A. Check the patient's blood type and the blood unit's compatibility. Explanation. When transfusion reaction occurs, it is critical to immediately verify the compatibility of the patient's blood type with the transfused blood unit. Reaction like fever, chills, and back pain could indicate hemolytic transfusion reaction, typically due to incompatibility between the donor and recipient's blood types. The first step in the investigation is to check the blood and cross-matching records. This will identify any errors that might have occurred during the matching process. Performing hemolysis test option C can help confirm if hemolysis occurred but would be done after compatibility has been verified. Reporting to the legal team option B or preparing another transfusion unit option D should not be the immediate focus without confirming the cause of the reaction. Question 7. A laboratory technician is performing a blood culture test and observes a yellowish pigment on the culture medium after incubation. The bacteria grow in a gram-positive coccate in clusters. Based on these observations, which of the following is the most likely pathogen? A. Pseudomonas aeruginosa. B. Staphylococcus aureus. C. Streptococcus pneumoniae. D. Clostridium difficile. Answer. B. Staphylococcus aureus. Explanation. Staphylococcus aureus is known to produce a golden or yellowish pigment which is characteristic of this organism. The presence of gram-positive coccate in clusters further supports this identification. Pseudomonas aeruginosa option A typically produces a greenish pigment, not yellow. Streptococcus pneumoniae option C appears as gram-positive diplococcii, not in clusters, and produce a yellow pigment. Clostridium difficile option D is a gram-positive rod that does not form clusters and does not produce a yellowish pigment. Therefore, Staphylococcus aureus is the most likely pathogen in this case. Question 8. During a hematology exam, a patient's blood smear is observed under the microscope, revealing a significant number of abnormal-shaped red blood cells. Some cells appear crescent-shaped, which could indicate a hemoglobinopathy. Which of the following diseases is most likely associated with this finding? A. Sickle cell disease. B. Iron deficiency anemia. C. Thalassemia. D. Aplastic anemia. Answer A. Sickle cell disease. Explanation: the characteristic crescent or sickle-shaped red blood cells observed in the blood smear are a hallmark of sickle cell disease. This hemoglobinopathy causes the red blood cells to adopt a sickle shape due to the abnormal hemoglobin HbS present in the blood. Iron deficiency anemia option B typically results in microcytic hypochromic red blood cells, not sickle-shaped cells. Thalassemia option C causes microcytic anemia but does not produce sickle-shaped red blood cells. Aplastic anemia option D involves a failure of bone marrow production but does not specifically lead to sickle-shaped cells. Question 9. In a clinical laboratory, a technician is performing a gram stain on a bacterial sample. The sample is determined to be gram-negative, and the bacteria appear as rods. What is the next best step in identifying the pathogen? A. Perform an antimicrobial susceptibility test to eye treatment. B. Perform an oxidase test to determine if the bacteria are oxidase positive or negative. C. Proceed with a complete blood count (CBC) to assess the patient's immune response. D. Directly administer broad-spectrum antibiotics to the patient. Answer: B. Perform an oxidase test to determine if the bacteria are oxidase positive or negative. Explanation: the first step in identifying gram-negative rods is to perform additional biochemical tests to narrow down the type of bacteria. The oxidase test is commonly used to differentiate between different groups of gram-negative bacteria. For instance, Pseudomonas species are oxidase positive, while Enterobacteriaceae oxidase negative. The antimicrobial susceptibility test, option A, may be useful later in the identification process but should not be performed before more specific identification steps. A. Option C is important in assessing the patient's overall condition but does not help in identifying the pathogen. Administering antibiotics, option D, before proper identification could result in inappropriate treatment. Question 10. A laboratory technician is tasked with performing a complete blood count (CBC) of a patient suspected of having a hematological disorder. The results show an elevated white blood cell count with a predominance of immature cells. Which of the following conditions is most likely associated with these findings? A. Chronic lymphocytic leukemia. B. Acute myelogenous leukemia. C. Iron deficiency anemia. D. Multiple myeloma. Answer: B. Acute myelogenous leukemia. Explanation: acute myelogenous leukemia or MEL is often characterized by an elevated white blood cell count with a predominance of immature cells such as blast cells in the peripheral blood. This is a hallmark of acute leukemia where there is rapid proliferation of abnormal white blood cells. Chronic lymphocytic leukemia, option A, generally presents with a less pronounced increase in white blood cells, does not feature a predominance of immature cells. Iron deficiency anemia, option C, typically leads to a decrease in red blood cell count, not an increase in white blood cells. Multiple myeloma, option D, involves plasma cell proliferation and can present with anemia but not an elevated white blood cell count with immature cells. Question 11. A 50-year-old patient presents with a persistent dry cough, night sweats, weight loss, and a history of being a smoker for 25 years. A chest X-ray reveals a mass in the upper lobe of the right lung. A biopsy confirms the presence of atypical cells. Which of the following is the most likely diagnosis? A. Small cell lung cancer. B. Tuberculosis. C. Non-small cell lung cancer. D. Pneumonia. Answer: C. Non-small cell lung cancer. Explanation: the patient's clinical symptoms, persistent cough, night sweats, weight loss, and history of smoking, along with the finding of a mass in the upper lobe on chest X-ray, are suggestive of lung cancer. The most common type of lung cancer is non-small cell lung cancer (SLC), which can be confirmed with a biopsy revealing atypical cells. Small cell lung cancer, option A, can also present with similar symptoms, but tends to metastasize earlier and more aggressively. Tuberculosis, option B, can cause night sweats and weight loss, but the chest X-ray findings would be more suggestive of granulomas or cavities. Pneumonia, option D, would not typically present with a mass on the X-ray and is less likely to be associated with weight loss and night sweats. Question 12. A microbiology laboratory receives a sample from a patient with suspected urinary tract infection (UTI). The culture grows a gram-negative bacillus that is urine positive. Which of the following organisms is most likely responsible for this infection? A. Escherichia coli. B. Proteus mirabilis. C. Klebsiella pneumoniae. D. Pseudomonas aeruginosa. Answer: B. Proteus mirabilis. Explanation: Proteus mirabilis is a gram-negative bacillus that is urease positive, meaning it can break down urea into ammonia, leading to an alkaline urine pH. This bacterium is a common cause of urinary tract infections, UTIs, particularly in patients with indwelling catheters or those with urinary tract abnormalities. Escherichia coli, option A, is the most common UTI pathogen but is not urease positive. Klebsiella pneumoniae, option C, can cause UTIs but is not as commonly urease positive as Proteus. Pseudomonas aeruginosa, option D, is another UTI pathogen but does not typically exhibit urease activity. Question 13. A 22-year-old female presents with the butterfly-shaped rash across her cheeks and nose, photosensitivity and joint pain. Laboratory tests reveal a positive on DNA antibodies. What is the most likely diagnosis? A. Rheumatoid arthritis. B. Systemic lupus erythematosus. C. Dermatomyositis. D. Psoriatic arthritis. Answer: B. Systemic lupus erythematosus. Explanation: the classic presentation of systemic lupus erythematosus (SLE) includes a butterfly-shaped malar rash across the cheeks and nose, photosensitivity and joint pain, along with positive autoantibodies such as ONA and DNA. These findings are highly suggestive of SLE. Rheumatoid arthritis, option A, involves symmetric joint involvement but does not typically present with butterfly rash or the specific autoantibodies associated with SLE. Dermatomyositis, option C, can cause a rash but usually involves a heliotrope rash, purple discoloration around the eyes, rather than a malar rash. Psoriatic arthritis, option D, is associated with psoriasis and usually affects the joints, but it does not cause a butterfly-shaped rash. Question 14. A 35-year-old male with a history of chronic alcoholism presents with confusion, ataxia, and ophthalmoplegia. The most likely diagnosis is A. Wernicke-Korsakoff syndrome, B. Alcoholic hepatitis, C. Acute pancreatitis, D. Delirium tremens. Answer: A. Wernicke-Korsakoff syndrome. Explanation: the combination of confusion, ataxia, and ophthalmoplegia in a patient with chronic alcoholism is highly suggestive of Wernicke-Korsakoff syndrome, which is caused by thiamine deficiency. Wernicke's encephalopathy, the acute phase, presents with confusion, ataxia, and ophthalmoplegia, and if left untreated, it can progress to Korsakoff syndrome, which is characterized by memory impairment. Alcoholic hepatitis, option B, involves liver inflammation and typically presents with jaundice and abdominal pain, not the neurological symptoms seen here. Acute pancreatitis, option C, causes severe abdominal pain and nausea, not neurological symptoms. Delirium tremens, option D, presents with agitation, hallucinations, and autonomic instability, typically in the setting of alcohol withdrawal. Question 15. A 60-year-old patient with a history of hypertension and smoking presents with sudden onset severe chest pain radiating to the back. Aiken reveals a tear in the aortic wall. What is the most likely diagnosis? A. Myocardial infarction. B. Pulmonary embolism. C. Aortic dissection. D. Gastroesophageal reflux disease. Answer: C. Aortic dissection. Explanation: the patient's sudden onset severe chest pain radiating to the back is classic for an aortic dissection. This life-threatening condition occurs when there is a tear in the aortic wall, allowing blood to flow between the layers of the vessel, leading to severe pain and potential rupture. The patient's history of hypertension and smoking increases the risk of aortic dissection. Myocardial infarction, option A, can present chest pain but does not typically radiate to the back, and the pain usually comes with other signs such as diaphoresis or shortness of breath. Pulmonary embolism, option B, typically causes pleuritic chest pain and shortness of breath. GERD, option D, may cause chest pain, but it is typically less severe and does not radiate to the back or have the associated risk factors. Question 16. A 60-year-old male with a history of hypertension presents with sudden onset severe headache, blurred vision, and nausea. On physical examination, his blood pressure is 200/130. A fundoscopic exam reveals retinal hemorrhages and papilledema. What is the most likely diagnosis? A. Cluster headache. B. Acute glaucoma. C. Hypertensive crisis. D. Migraine. Answer: C. Hypertensive crisis. Explanation: the patient's clinical presentation, including severe headache, blurred vision, nausea, and significantly elevated blood pressure 220/138 G, along with retinal hemorrhages and papilledema on fundoscopic exam, is most consistent with a hypertensive crisis. This is a medical emergency that can lead to organ damage, including the retina, brain, and kidneys. Cluster head. Option A, typically present with unilateral, excruciating pain around the eye and autonomic symptoms, e.g. lacrimation, not blurred vision, or fundoscopic changes. Acute glaucoma. Option B, presence with severe eye pain, nausea, and vomiting, but is not associated with high blood pressure or retinal hemorrhages. Migraines. Option D, can cause severe headaches, but do not cause papilledema or significant changes in blood pressure. Question 17. A 45-year-old female with a history of type 2 diabetes mellitus presents with recurrent episodes of blurry vision, frequent urination, and increased thirst. Her fasting blood glucose is 175 mdl. Which of the following is the most appropriate next step in management? A. Initiate insulin therapy. B. Monitor blood glucose for 1 week. C. Prescribe oral hypoglycemic agents. D. Advise the patient to monitor her blood glucose at home and return in 6 months. Answer: C. Prescribe oral hypoglycemic agents. Explanation: Is patient presents with symptoms consistent with uncontrolled diabetes, blurry vision, frequent urination, increased thirst, and a fasting blood glucose level of 175 mg/dl, which is above the target range for type 2 diabetes. The first step in managing uncontrolled type 2 diabetes is typically to initiate oral hypoglycemic agents, such as metformin or sulfonylureas, to help lower blood glucose levels. Initiating insulin therapy, option A, is generally reserved for patients who have more severe hypoglycemia or difficulty controlling their blood sugar with oral medications. Monitoring blood glucose for 1 week, option B, without intervention, is not appropriate for this patient with clear signs of uncontrolled diabetes. Advising the patient to monitor blood glucose home and return in 6 months, option D, is also inappropriate, as this patient needs active management. Question 18. A 70-year-old male with a history of heart failure and atrial fibrillation presents with worsening dyspnea and orthopnea. Physical examination reveals bilateral crackles in the lungs and jugular venous distension. His blood pressure is 110/7 mmHg and heart rate is 90 bpm. What is the most likely cause of his symptoms? A. Pulmonary embolism. B. Acute exacerbation of chronic obstructive pulmonary disease, COP. C. Acute decompensated heart failure. D. Pneumonia. Answer: C. Acute decompensated heart failure. Explanation: The patient's history of heart failure, along with symptoms of worsening dyspnea, orthopnea, bilateral crackles on lung auscultation, and jugular venous distension, strongly suggest acute decompensated heart failure. In heart failure, the inability of the heart to pump blood efficiently leads to fluid buildup, often resulting in pulmonary edema manifesting as crackles and dyspnea. Elevated jugular venous pressure. Pulmonary embolism, option A, could cause acute dyspnea, but would typically present with a sudden onset of sharp chest pain, tachypnea, and hypoxia, which are not seen here. Acute exacerbation of COPD, option B, typically presents with increased sputum production and wheezing, not the signs of fluid overload seen in this patient. Pneumonia, option D, may present with dyspnea and crackles, but it would also associated with fever and a productive cough, which are not mentioned in this case. Question 19. A 40-year-old female presents with a new-onset, non-tender, firm mass in her left breast. She has no significant medical history and no family history of breast cancer. A mammogram and ultrasound reveal a well-circumscribed hypochoke lesion. The most likely diagnosis is A. Fibroadenoma, B. Breast carcinoma, C. Intraductal papilloma, D. lipoma. Answer: A. Fibroadenoma. Explanation: The most likely diagnosis for a firm, non-tender, well-circumscribed hypochoke breast mass in a young, otherwise healthy female is a fibroadenoma. These benign tumors are common in women under 40 and are typically painless and mobile on physical examination. Breast carcinoma, option B, is less likely given the patient's age and the characteristics of the mass, as breast carcinoma often presents a regular hard mass with poorly defined borders. An intraductal papilloma, option C, is a benign growth of tissue in the breast ducts that may present with nipple discharge, which is not noted here. A lipoma, option D, is a soft, mobile, non-tender fatty mass, but it is usually less firm and does not typically appear hypochoic on ultrasound. Question 20. A 25-year-old female presents with a new rash on her face, chest, and upper arms. The rash is erythematous and raised, with a scaly appearance. She reports that it has been worsening over the past few weeks and that she has had joint pain in her hands. Her mother has a history of rheumatoid arthritis. What is the most likely diagnosis? A. Psoriasis. B. Systemic lupus erythematosus. C. Rheumatoid arthritis. D. Dermatomyositis. Answer A. Psoriasis. Explanation: the patient's erythematous, raised, scaly rash, particularly on the face, chest, and upper arms, in combination with joint pain, is most consistent with psoriasis. Psoriasis is a chronic autoimmune condition that typically presents with well-defined, red, scaly plaques, often on the elbows, knees, scalp, and upper body. Systemic lupus erythematosus, option B, can also present with a rash, but it typically involves butterfly-shaped malar rash across the cheeks and nose, not a scaly raised rash. Rheumatoid arthritis, option C, primarily affects the joint and does not typically present with a rash. Dermatomyositis, option D, involves a characteristic heliotrope rash, purple discoloration around the eyes, and can cause muscle weakness, but it is not usually associated with the type of rash seen in this patient. Question 21. A 60-year-old male with a history of smoking presents with persistent cough, hemoptysis, and weight loss. A chest X-ray reveals a mass in the upper lobe of the left lung. What is the most likely diagnosis? A. Pulmonary tuberculosis. B. Non-small cell lung cancer. C. Pneumonia. D. Acute bronchitis. Answer B. Non-small cell lung cancer. Explanation: the patient's symptoms of persistent cough, hemoptysis, coughing up blood, weight loss, and a chest X-ray showing a mass in the lung are highly suggestive of non-small cell lung cancer (SLC), particularly given the patient's history of smoking, which is a major risk factor for lung cancer. Pulmonary tuberculosis, option A, can also present with chronic cough and weight loss, but it would typically be accompanied by other signs such as night sweats and fever, and may show cavitary lesions on imaging. Pneumonia, option C, often presents with fever, productive cough, and localized lung infiltrates on X-ray, not a mass. Acute bronchitis, option D, typically causes a cough, but it does not cause weight loss or a lung mass on X-ray. Question 22. A 35-year-old female with a history of hypothyroidism presents with fatigue, cold intolerance, and dry skin. On examination, she has a slow heart rate and coarse, dry hair. Her thyroid-stimulating hormone TSH level is elevated and free thyroid sign is low. What is the most likely diagnosis? A. Graves' disease. B. Hashimoto's thyroiditis. C. Subclinical hypothyroidism. D. Primary hypothyroidism. Answer B. Hashimoto's thyroiditis. Explanation: the patient's symptoms of fatigue, cold intolerance, dry skin, and physical findings of a slow heart rate and coarse hair, along with an elevated TH and low Freed, are consistent with primary hypothyroidism. Hashimoto's thyroiditis, an autoimmune condition, is the most common cause of primary hypothyroidism. Graves' disease, option A, is associated with hypothyroidism, and would present with symptoms like weight loss, tremors, and a rapid heart rate. Subclinical hypothyroidism, option C, is diagnosed when TH is elevated but free T is normal, and patients typically do not have overt symptoms. Primary hypothyroidism, option D, presents with low TH and high free T, causing symptoms such as weight loss, heat intolerance, and tremors. Question 23. A 22-year-old female presents with a painful, swollen right knee after playing basketball. On examination, there is tenderness over the anterior knee and swelling. A positive Latchman test is noted. What is the most likely injury? A. Medial collateral ligament, MCL, sprain. B. Anterior cruciate ligament, ACL tear. C. Patellar dislocation. D. Meniscal tear. Answer B. Anterior cruciate ligament, ACL tear. Explanation: the positive Latchman test, which involves assessing anterior translation of the tibia relative to the femur, is highly suggestive of an anterior cruciate ligament, ACL tear. ACL tears are common in athletes, especially during sports that involve jumping or pivoting. MCL sprains, option A, would present with tenderness along the medial aspect of the knee and would not result in a positive Latchman test. Patellar dislocation, option C, typically causes knee instability and may present with a visible deformity, but it does not produce a positive Latchman test. A meniscal tear, option D, can cause knee pain and swelling, but it is more commonly associated with a positive McMurray test and is less likely to a positive Latchman test. Question 24. A 45-year-old male with a history of alcohol use disorder presents with confusion, ataxia, and ophthalmoplegia. On examination, he has nystagmus and a wide-based gait. What is the most likely diagnosis? A. Wernicke's encephalopathy. B. Korsakoff syndrome. C. Alzheimer's disease. D. Delirium tremens. Answer A. Wernicke's encephalopathy. Explanation: the patient's symptoms of confusion, ataxia, ophthalmoplegia, and nystagmus combined with a history of alcohol use disorder are characteristic of Wernicke's encephalopathy. This condition is caused by thiamine vitamin B deficiency, commonly seen in chronic alcoholics. It is a medical emergency and requires immediate treatment with thiamine supplementation. Korsakoff syndrome option B is sequela of Wernicke's encephalopathy, characterized by memory impairment and confabulation, but it does not typically present with the acute symptoms of ataxia and ophthalmoplegia. Alzheimer's disease option C usually presents with gradual memory loss and cognitive decline without the acute neurological signs seen in this patient. Delirium tremens option D occurs during alcohol withdrawal and is associated with severe agitation, tremors, and hallucinations, but it does not typically cause the ophthalmoplegia and nystagmus seen here. Question 25. A 40-year-old male presents with a painful, swollen right ankle after an inversion injury while playing soccer. On physical examination, there is tenderness over the lateral malleolus, swelling and bruising. Ankle X-ray shows no fractures. What is the most likely diagnosis? A. Achilles tendon rupture. B. Lateral ligament sprain. C. Medial malleolus fracture. D. Posterior tibial tendonitis. Answer: B. Lateral ligament sprain. Explanation: the patient's presentation of ankle swelling, bruising, and tenderness over the lateral malleolus after an inversion injury is most consistent with a lateral ligament sprain, particularly involving the anterior talofibular ligament (AFL). This is one of the most common ankle injuries and often occurs during sports or activities that involve sudden twisting motions. An Achilles tendon rupture option A presents with sudden severe pain in the back of the ankle and an inability to plant or flex the foot. A medial malleolus fracture option C would typically cause tenderness and swelling on the medial side of the ankle, not the lateral side. Posterior tibial tendonitis option D causes pain along the medial side of the ankle and is not usually associated with an inversion injury. Question 26. A 55-year-old female presents with increasing shortness of breath and fatigue. On physical exam, she has a loud air, a prominent second heart sound, and a low-pitched diastolic murmur at the apex. What is the most likely diagnosis? A. Aortic stenosis. B. Mitral stenosis. C. Tricuspid regurgitation. D. Pulmonary hypertension. Answer: B. Mitral stenosis. The explanation: the findings of a loud air, prominent air, and a low-pitched diastolic murmur at the apex are characteristic of mitral stenosis. This condition is commonly caused by rheumatic fever and results in impaired blood flow from the left atrium to the left ventricle, leading to symptoms of heart failure. Aortic stenosis option A presents with a systolic ejection murmur and can lead to a delayed or weaker pulse. Tricuspid regurgitation option C typically causes a holosystolic murmur along the lower left sternal border. Pulmonary hypertension option D may present with right-sided heart failure symptoms but does not cause the characteristic murmur described. Question 27. A 30-year-old male presents with a painless lump in his left testicle that has been gradually enlarging over the past month. On examination, the lump is firm, non-tender, and does not transilluminate. What is the most likely diagnosis? A. Epididymal cyst. B. Testicular torsion. C. Testicular cancer. D. Varicocele. Answer: C. Testicular cancer. Explanation: a painless, firm, non-tender testicular lump that does not transilluminate is highly suggestive of testicular cancer. Testicular cancer is the most common malignancy in young men and typically presents with a solid mass. Epididymal cysts option A are usually painless and transilluminate, and they are located in the epididymis rather than the testicle itself. Testicular torsion option B is a surgical emergency that presents with acute scrotal pain and swelling, not a gradually enlarging painless lump. A varicocele option D is a dilated vein in the spermatic cord and is usually described as a bag of worms on palpation, not a firm mass. Question 20. A 45-year-old female with a history of hypertension presents with sudden onset of severe headache, nausea, and vomiting. She is noted to have a blood pressure of 210/100 mmHg. On examination, she has papilledema. What is the most likely diagnosis? A. Tension headache. B. Subarachnoid hemorrhage. C. Hypertensive emergency. D. Migraine headache. Answer: C. Hypertensive emergency. Explanation: the patient's symptoms of a sudden onset of severe headache, nausea, vomiting, and elevated blood pressure 210/100 mmHg along with papilledema are most consistent with a hypertensive emergency. This is a life-threatening situation where blood pressure must be rapidly reduced to prevent organ damage, particularly to the brain. Tension headaches option A are typically associated with mild to moderate pain and do not cause nausea, vomiting, or papilledema. Subarachnoid hemorrhage, or option B, presents with an abrupt thunderclap headache and is usually associated with a history of trauma or aneurysm, though it can also occur without warning. Migraines, option D, are often present with unilateral headache, photophobia, and phonophobia, and do not typically cause severe hypertension or papilledema. Question 29. A 72-year-old male presents with difficulty swallowing both solids and liquids, along with the sensation of food sticking in his chest. On examination, he has a history of progressive weight loss and hoarseness. What is the most likely diagnosis? A achalasia, B. Esophageal cancer, C. Gastroesophageal reflux disease, GERD, D. Peptic ulcer disease. Answer: B. Esophageal cancer. Explanation: the patient's symptoms of progressive dysphagia, difficulty swallowing both solids and liquids, weight loss, and hoarseness, particularly in an elderly male, are concerning for esophageal cancer. This malignancy often presents with progressive dysphagia and weight loss due to obstruction of the esophagus. Achalasia, option A, also causes dysphagia but usually presents with difficulty swallowing liquids initially and no associated weight loss or hoarseness. Option C typically causes heartburn and regurgitation, and while it can cause dysphagia, it does not cause the severe weight loss or hoarseness seen here. Peptic ulcer disease, option D, is more commonly associated with epigastric pain, nausea, and vomiting rather than dysphagia. Question 30. A 60-year-old male with a history of type 2 diabetes and hypertension presents with sudden onset of painless vision loss in his right eye. On examination, the right retina appears pale with a cherry red spot at the macula. What is the most likely diagnosis? A retinal vein occlusion, B. Retinal artery occlusion, C. Diabetic retinopathy, D. Macular degeneration. Answer: B. Retinal artery occlusion. Explanation: the sudden onset of painless vision loss with a pale retina and a cherry red spot at the macula is characteristic of retinal artery occlusion. This condition is often caused by embolism or atherosclerosis, and it typically results in sudden severe vision loss. Retinal vein occlusion, option A, usually presents with retinal hemorrhages and venous dilation, not a pale retina and cherry red spot. Diabetic retinopathy, option C, typically causes gradual vision loss with findings such as microaneurysms, retinal hemorrhages, and exudates, but it is not associated with the cherry red spot. Macular degeneration, option D, causes gradual central vision loss and is not associated with acute vision loss or the findings seen in this case.